Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Gary Dykes, and he's going to talk about differentiating between the lumbar spine, the SI joint, and the hip. Gary is part of the McKenzie Institute faculty since 2005. I hope you enjoyed the show. Hi Gary, welcome to PT Pro Talk. How are you today?
Doing well. How are you?
I'm doing well. So let's jump right into our questions. It took us a little bit to get this going, so I'm excited to talk about hips, SI joint, lower back, and more things. So just tell us a little bit about yourself, your background, and how did you get to where you are right now?
It seems time has really flown by since I got started in this, and I got out of school in '96. And then pretty quickly after that, I realized that I was very frustrated with my ability to assess musculoskeletal problems, in particular lumbar problems. And I can remember those patients making me very frustrated and uneasy. And so then, again, my course was, again, I tell people all the time, by chance. So I feel very, very, very fortunate to be where I'm at right now, because I feel like I would, for some reason, was steered that way, but it wasn't because of my knowledge. I took the first lumbar course I could get to in 1997, and that was only because it was in Atlanta, and it had nothing to do with McKenzie. And so it could have been a Maitland or a Paris or a whatever course. I just knew I needed to know more about something. And so when I went to that course and I listened to what was being said and how they assess patients, and I think the assessment of the patients and realizing that, and it was Mark Miller's course then, it was in '97, realizing he was having a conversation that meant something with the patient. And I thought, wow, that's what I don't do right now currently. So I need to know how to do that. And so from that point forward, and there was some little hiccups here and there, but from that point forward, I knew there was more I needed to do better. And that was the way I wanted to do it. And so from that point, I think through 2001, I think is when I took my credentialing exam in Ottawa, Canada. And that was where our conference was scheduled to be over the past 2 years. And unfortunately, we have not made that trip because of COVID. And I think we're all looking forward to that face-to-face time again sometime soon. And then shortly after that, or right after that, as soon as I took the credentialing exam, signed up for the diploma program and went to my residency in Texas, Austin, Texas in 2002, and passed the diploma exam in 2003. And that was a really fun trip too. That was to Rome, Italy to do that. So the traveling is always a nice perk, right? Yeah, so it's fun. And so it's been a nice course. I look back on that and think, man, wow, if you had drawn that up for me, I'm not sure I would have really believed it. But it was really a fun thing. And since then, I've been in faculties. Again, these things kind of fell into place. After the diploma, there was, I think, an uptick or a need in the Institute for instructors. I knew I had something that I always wanted to do and enjoyed doing, which was teaching others, like talking, interacting with people. And so I thought, well, I'll give this a try. And so I signed up to be considered for faculty. And that started, I think, in 2005, probationary. And then now, here we are in 2021, and it seems like yesterday, but a lot of great fond memories, over those years. So, yeah.
So that's crazy. Everything happened so quick. You just left college and then you started, and then the credentialing and then the diploma. You were like, you didn't waste any time.
Yeah. It sounds like I had a plan, but that wasn't the case. There was no plan. It just happened. So it's good.
Yeah, that's awesome. Everything back to back to back, and you're done. You're a faculty.
Yeah, so it's, I met some really great people along the way, like Christy McGuire and Dave Oliver and Cora Tone and all those guys, John Weinberg. And I know I'm leaving folks out, so I apologize for that. But, and not to mention our mentors that we all look up to, and that's, the senior faculty to me. And man, everybody's just like family. So it's fun.
That's awesome. So now, let's talk about differentiating between lumbar spine, SI joint, and the hip. So we know sometimes it's confusing to differentiate them. So from the subjective history, what are the signs that help you to differentiate?
The biggest thing there, I think, and I always try to push this, on courses, is early on, you need to look and do a very thorough job of establishing the body diagram. And so the body diagram is probably your first best indicator that you may have some information from, which means, okay, so if you're looking at SI joints, and then you consider hips, and so you have you could have you have a bilateral, or you have two of those things to consider. Those usually have symptoms that are unilateral. So you'll see something on one side versus on both sides, or certainly not in midline. So if you go to a lumbar complaint and you say, okay, where are your symptoms? Commonly, they're going to tell you where they hurt the most or have the most symptoms, which is, okay, let's say right side, low back. Okay, well, first thing that pops in your mind, I can remember back when I was out of school, first thing I would think is probably SI, because that's where it hurts. But then if you ask the next question, it's like, is there any problem with your left side? Most people will discount the left side because it doesn't hurt as bad as the right, and they want you to know the right hurts. And so it's like, but it does. And so it does cross midline. So right there, first and foremost in the body diagram, I would say, listen, lumbar pain can be at midline. It can be bilateral. So if you really do a thorough job of establishing the body diagram, I think it will eliminate some of the early confusion of, is this really, could this be an SI? Could this be a hip? Now, could you have bilateral SI problems, or could you have bilateral hip problems? And in 25 years of being a therapist and doing this at a decent level for, I think, most of those, I hope. Yeah, sure, I've seen a couple of those, but it's not the common theme, right? So you go with I always tell people there are very few zebras, right? So don't look for zebras, look for horses. So go with what the odds are best likely. And so midline and across the back, bilateral complaints tend to be lumbar. So that would steer your questions and thoughts there. And if it is truly unilateral, and you do establish that it is unilateral, then maybe there is some further consideration there for an SI or a hip problem. And so, yeah, that's where I would first start at, eliminating those things or considering those things. Other things to consider, again, going back to the body diagram, is doing a real good job of establishing if there's any distal symptoms. Below the knee is a little more rare. Again, we're talking horses here, not zebras. And so below the knee, I would, lean more towards a lumbar complaint versus a hip or an SI, just from the referral pattern, because you can have a radicular symptom from the lumbar, and you're not classically going to have that symptom from SI or hip. And then certainly into the foot, or any numbness or tingling, right? So those things would, again, steer you towards lumbar versus it being a hip or SI. And so I feel like that's important. And I think that a lot of early clinicians that don't have the time and the experience sitting in with patients and establishing the body diagram, they don't do a great job at doing that, because they don't want to ask the next question. The next question, they feel like they might be badgering the patient a little bit, and I think it's important, even the subtle things that they may not feel like is important, or may not feel like is associated to their complaint, may very well be a big part of their complaint. And so I say lots of times, if they go, okay, I go back to my right low back. My right low back is bothering me. So you color that in, and you say, is there any other areas, that you had trouble? And they go, well, have a little bit of pain in my thigh. Okay, well, now the thigh. Okay, does it ever go below the knee? Well, one time last week, I think I felt some things. So then all of a sudden you go to your Treat Your Own Back book, and you open up the, centralization page, and now your body diagram has changed entirely. So your consideration has changed entirely. So I think it's important to do that. And so then considering, the bilateral, midline and bilateral, below the knee, foot type symptoms, those type things are really strong indicators that you're looking at something lumbar versus the hip and SI. Let's see, what else have I got here? And I guess in history, since you were specific with that, at onset, I think with, and this is again, something I feel like I lean on a decent amount, especially when someone's maybe comes into the clinic thinking SI joint, is how did it start? And so typically, if you're going to see that, there's going to be a high prevalence, I think, in that population, if they truly are, to have had some sort of trauma in their past be it a fall, be it an accident, or maybe they've had some recent, either they are or recently have been pregnant. And so those things, those events like that make that potential of an SI greater. And so, okay, now I'm at least listening, to that, especially with a body diagram that suggests it could be, right? So,
yeah.
And so that's, those are some of the big key things there. I think with lumbar and with hip for sure, you'll see a little bit more of an insidious onset. So if you ask someone how did it start, I guess classically you look back and the vast majority of those are going to be, they're not sure, or they may try to come up with a reason why it might be, but it's not really the true cause and effect.
Yeah. So I was just thinking about the session better and worse. What makes your pain better and makes worse? Is there any positions or things that make you think more about lumbar or hip or on that session?
With lumbar, obviously, with what we're, and I'll go back to, because I'm sitting here as I go through, and typically these things pop up as you go along, the location of the complaint too. And this is a body diagram thing, so sorry for going back to that. Classically a hip complaint, if you're going to consider that, you would figure that you're going to have a groin thigh symptom, not a buttocks back symptom. That's just not classically what you'll see. So again, trying to differentiate out that. And again, these are things to put into your thought process. These are not definitive things, but the case builds as you go along, right? And so can a lumbar complaint cause groin pain? Yes. Does an SI joint cause groin pain? Can, right? So that kind of, but it does, if it's not in the groin, then I'm really not thinking a lot about the hip as much so. And I'm not thinking as much about the hip, especially if it's a unilateral, bilateral back, buttocks, and groin. So then you got to screen the lumbar out for that. So going back to your question, worse, better. I think with lumbar classically, and hopefully most folks that are listening to this, the curve reversal from sitting. Right? So they'll sit, flexion is provocative, it's obstructive, the rising is difficult. And so the first few steps are as they move, they feel better, right? And so a hip can be that way. And so identifying where they may feel that stiffness. So when you rise out of the chair and you take those first few steps, if they're not great, those two may sound a lot alike. So I rise, I feel stiff. My first few steps aren't great. And so as I move along, I feel better. So identifying, say, okay, when you rise, where do you feel the stiffness? Is it in your back or is it in your hip or groin area, right? So identifying that can help you at least get a suggestion towards, is it a lumbar or hip potentially? But again, I will go back and state that, do you see growing hip pain that is lumbar, that does feel stiff at the hip when they rise? Yes, you do. So again, you have to differentiate top down, lumbar down, as to whether where your source is at. SI joint, when you look at that, I feel like that you may hear pain when you change or transition, but I don't feel like you're going to see as much obstruction or stiffness. So you may have pain during the motion, but maybe not as much obstruction. Again, I feel like that's a classic sound possibly for that. Now, some people may say, well, I saw a guy or a girl one time that did. It's like, okay, again, what's your vast majority going to look like? And then SI joint is a loaded, so when you load through that joint, just the same as the hip, I think as you make impact to that, and commonly, again, this is going with the most common things, a lumbar complaint, as you walk and you move further, especially your sagittal plane responders, they feel better. They're on the move, they're going, they feel best. I feel like peripheral joints, as you ask the peripheral joint to do more of what it's designed to do, that it will perform less and less well, right? So as that joint, if it's not a sound joint, then somewhere along the lines, it will start to become problematic again, right? So it may feel better in between, but there's a limit to that. So just some thoughts, from a peripheral joint perspective. And I know that the SI joint classically in our manuals and things is in the other box, right? But again, if you look at it from how it looks on the body, there are two of them, and it's somewhat peripheral to the axial joint. So I don't know that it's not the first peripheral joint, if you think of it from that perspective. But it again, like the hip, I think as you ask it to do, or if you ask that shoulder to do more of what it's designed to do, I think it performs less and less well if it's the true source of the problem.
Yeah, no, that makes sense. A lot of good tips. And I was just thinking while you were talking, relating to my back pain one time. I had like hip pain for a long time and a lot of weaknesses on the thigh, inner thigh, and glutes and all of that. Going to doctors, that was prior being a PT and McKenzie, going to doctor, and then they saying that was like, that's like a glutes tendinitis or like something like that on the muscle. You know, when you go, you massage, you stretch, you do all of that, and of course it doesn't help. And then after, when I started doing McKenzie, I was the patient of another clinician, and then we found out my upper back, lower thoracic, the area there, once you put like you did and assessed and put the pressure in the right direction, then just the strength got back super quick. And it's just amazing how these things, it looked like a lot was hip, but because the symptoms were there, but the SARS wasn't. So I think that can be very confusing.
Yeah, and that's a great point too. And I know we're not necessarily, looking at or talking about the physical exam piece of it just yet, but when you look at that, if you're looking at a complaint that is inconclusive and it's above knee, then I would strongly encourage, looking at the lower thoracic upper lumbar joints. And so I think we do what we see as participants. So you may see one of us on a course and everything is pretty well straightforward. We can explain it, the patients are improved, and it's great. But I think sometimes those that seem the easiest, we learn the least because you don't see us struggle with figuring out where and how we might do that. So I think the upper lumbar joints, the lower thoracic joints have to be considered for sure, especially in an inconclusive above knee complaint. So if your body diagram is that, and it seems to be that, and you just are sitting scratching your head, then I would strongly suggest looking at that. I had a patient in Nashville, matter of fact, that I was there teaching a course, and they were scheduled for a labral repair for their hip. And it just, in talking about things like we're talking about, the history didn't suggest that it was a hip issue. It just didn't sound like a classic hip issue. So I kept, and for lack of a better way of putting this, I kept tinkering around with things and, ended up with upper lumbar. And it was an upper lumbar issue with a lateral component. Oh. And so when I assessed her through mobilization in the upper lumbar, lower thoracic joints, she could barely stand up off the table. Like, it was profound, to say the least, the change that happened. And I thought, well, now we know, right? So dramatically worse with mobilization. She could barely bear weight through her foot, which was key to her. That was part of her onset of symptoms. And then she needed to be in rotation and flexion to get back to where she could actually move and function. And so I don't know whatever happened with that case, but the question was then, well, what do I do about my labral repair? And I thought my thought is I would not consider anything structurally, surgically necessary until I figured out the lumbar component. So so again, that was a neat experience there. And that's been, gosh, that may have been 10 years ago now, it seems, maybe 8. But it was a really neat thing to see. I think the participants were surprised. Honestly, as we move through time and we do a better job, and I think we all are doing a little better job than we were 5 years, 10 years ago, we see things like this to help us build on. And so that was a case that stood out in my head when we knew we were talking about this. So, yeah.
Yeah, because that's what's crazy. I think everybody deserves to have an assessment prior to doing anything structural, because then you can find out later that that's not really the case, or the back was influencing way more on the symptoms than what we thought it was hip, or just giving a fair chance to everybody, which doesn't happen all the time. So yeah, that's.
And I'm sure with your podcast that someone has mentioned, or the expo study that's out there with the axial joint, influence on the peripheral joint complaints. And wow, I don't think you could find a better, validation for that statement you just said. You just get an unbiased mechanical assessment. Maybe you do need the surgery, but if you do need it, at least go in confidently with an expectation it's going to help you, right?
Yeah, yeah, absolutely. So now let's go to the objective exam. Do you have anything else to talk about subjective?
No, let me see. Let me look at my list here. I think I covered everything that I can think of. Lumbar, again, by and far, most common is going to be your biggest, most common thing. Then I would move to hip and then SI as far as the what do you see most. And I'll say this too, 20 years ago, that was what it seemed like everyone came in talking about. My SI, my SI, my SI. Maybe it was just a spot or a little, maybe that was my cohort at the time. But current times now, I don't see as much of a suggestion for that. So I don't know if it's faded somewhat and we feel like we got a better understanding of what it is and how it looks and behaves overall in medical, or if it's just where I'm living and it's a different cohort. So I don't know, but I don't see as much of that now. I think I spend, if there is a differentiation, I spend most of my time differentiating lumbar and hip.
Yeah. It doesn't feel that is as common, at least, to have that cases.
Occasionally courses, there will be different, like you'll see questions that pop up about the SI joint. It's like, wait a minute, I hadn't had that question in 5 years, but it's not as common.
Yeah. I remember when I was doing the course, it was like a very short part. It was about SI joint. You didn't talk a lot about it and it didn't feel like it was as important. So now about the objective exam. So what are the tests that help you to make the diagnosis?
Okay, so again, I think and this is the biggest part of this is an inconclusive lumbar exam, right? So I hear a problem. I think I understand that problem. I'm going to look for baselines for that problem, which again, you may see loss of motion at the hip, which is, would be the one thing that you would expect to even consider there being a hip or an SI issue, is that I would need to see something that suggests that joint could potentially be at fault. So I would need that baseline to be there. If someone's hip moves fully well and there's no complaint there, then that's probably not the joint, right? We need to look harder where we were at. But an inconclusive lumbar exam, I think, is the part that we miss most. And so the history would suggest a certain scenario. The physical exam, again, would probably show, I would expect some obstruction to movement or loss of motion there to be concordant to their history, their complaint, and then testing through the lumbar. Now, again, if you test through the lumbar and you think, okay, this looks and smells like it could be lumbar, but then it turns out that it's not, and then going to those baselines you established at the hip would be my next move. So what do those baselines have to do with their complaint? So then I would consider looking at the hip and then lastly looking at the SI. But the inconclusive lumbar exam, and some people say to me, well, what does that look like? I think that, again, first and foremost, that if you feel like you have a joint that's at fault, so let's say it's the lumbar component, there should be some sort of influence. I feel like if you have someone, let's just say you test them for 48 hours, 72 hours, whatever, if they're doing something that you're having them do every couple of hours and they're doing hundreds of reps over time, if they come back and they say, same, okay, that same is like, okay, I be worse, but not the same, right? So something should change if you're moving the joint, that needs to be moved, I think. So at that point, I would consider progression of force, right? So I might look at, clinician overpressure mobilization, and I might look at different levels, right? So I just mentioned lumbar lower versus mid versus upper, and then reassess those baselines. If I'm moving through that progression of force and I'm still inconclusive, then I'm going to move out to the hip and I'm going to assess what repeated movements might do for that. And so again, differentiation lumbar, if you choose to test it, if you got time for that, you can spend a visit. I would, find what I think might be our best likely look at that, whether it be extension or flexion. I would have them on, on task for that and any postural changes you might need. And then looking for confirmation, which is, again, one of those things I see young therapists make the mistake of is, I had them do some extension or I had them do some flexion. And the first question that you might get asked, I know by me, would be why? So what are you looking for? What do you expect to happen? And what are you going to do with that information when it comes back to you? So okay, I think that I have a lumbar derangement. It sounded like that in the history. It looked like that in the physical exam. And so I sent them out testing for me because I didn't have a strong confirmation in the clinic. Okay, then great. Then when they come back and they say I'm the same, now what do you do, right? Because you didn't get I'm better and you didn't get confirmation you're right. So now we got to continue to sort this out. So progression of force, yellow light, right? Proceed with caution, but those people need to be better understood. So that would lead to clinician overpressure, to immobilization or maybe a change in direction to get better clarity. So if you extended them, you might flex them. If you flex them, you might extend them. But either way, you got to start to doubt or challenge your thought process because you don't have confirming information. So move out to the hip again. There's a loss of motion there. Then I would, move to the hip next, and I would start to move that to in range, and then reassess baselines, symptomatically, mechanically, functionally. And so that would be how that would work through. So the algorithm, I think, in our text, our manuals is, lumbar confirmation, yes or no. Okay, if yes, proceed with lumbar. If no, then consider hip. Okay, I move the hip. The hip doesn't give me the answer. Now look at SI, right? So you work through that way.
Yeah.
If that makes sense.
Yeah, no, it does. And then let's throw the SI joint in the middle. So
okay.
how would you test?
Middle, Ariana. It is in the middle, right? I have my kids would say that's bad. So not funny, right?
It is literally in the middle. Yeah.
That's right. So I think the easy thing here is I think it's been, if you look at our at the OCS, the material they present there and say, what do you do with the SI? What does that mean? What would you look at as being, good evidence that you have an SI joint problem? And that's Laslet's test. And so, distraction gapping, posterior shear, thigh thrust, compression, sacral thrust. I've got my stuff over here in my book I'm looking at now. And so if you look at those tests and you have those tests and you show, I think 3 of 5 of those positive, if you get, so they're provocative tests. So they should be concordantly painful, right? So you've got a inconclusive lumbar. You haven't found your answer in the hip. I'm going to go ahead and do these provocative tests. So remember, they got to be concordantly painful, meaning that you have to reproduce that patient's pain that they came with. So you can't do, a distraction gapping test and get a completely different symptom, and that symptom, and you consider that to be positive. It has to be their complaint, right? And so challenging through those things. And so if you get those tests and you start to see that you have some positive tests, then there you may find that you have an SI joint problem. And if you do confirm that, again, classification is key, right? We talk about that, derangement, dysfunction, posture. And I think, by and far, you're going to see mostly derangements, right, out of those classifications. And so if you start to do those things, even in your test, if you look at Gainsland's test, pelvic torsion, which I left that off. So if you look at that pelvic torsion test, a lot of times you can start to see or appreciate a directional preference for that. So you'll get a posterior rotation or an anterior rotation suggestion that might be your movement, right? And so through the exam of using those tests, those provocative tests, you may start to see or realize that there's a directional preference for that joint just the same. And then it's just a matter of figuring out the load, whether it's a unloaded, partial load, or fully loaded test that you need. And so, or repeated movement. And so the Laslet's tests are the ones we lean on. We all teach them. We all use them. If you ask me, Gary, when's the last time you used those tests in an inconclusive lumbar or hip, then I would tell you I can't remember, right? Because I can't remember when that's last happened. Now, maybe you could say, well, Gary, you're just missing a bunch of them. Okay, that's fair. Maybe that's true. I don't feel like it's true, but it might be. But I will say that I do use those tests sometimes when people, if I have the rare occasion, come in and they say, I have an SI joint problem. And they're in the narrative that they give you is, I have an SI joint problem. I've had this SI joint problem for years. My doctor says I have an SI joint problem. Then I'll say I will lead into that by going straight to those tests, right? Knowing that they can be false positives, and then assess the lumbar spine and reassess the test. If the tests are then now negatives, then they don't have an SI joint problem. They have a lumbar problem. So I manipulate the information in sort of in reverse to get the patient away from, hey, my SI joint okay, maybe I need to consider this lumbar thing, right?
Good strategy. I like that, because if we do our rationale and let's start with the back to eliminate the back as the source. A lot of times the patients don't like, and they want you to go straight to where they think it's the problem. So
so go to it, right?
Yeah,
So here's my problem. Okay, well, let's test that. Okay, we got these, and here's the test we're going to use. So I use a dry erase board a lot, and so I would write those tests on there, right? So they know here's what we're going to do, and I would check the ones that are positive, and then I would have them repeat a movement, lumbar, and then go back and retest. If they're negative, it's like, okay, these are now negative, and that was what did it. So, there's our reasoning, right?
Yeah. So in the SI joint, what would be the most common direction if you get a derangement? Would also be extension?
Oh man, I think I would probably gamble to say that's true. So some degree of, partial to full load, extension. Of course, that looks a lot like your hip extensions, that you see in our manual and the text and the treacher on hip. And so, I think you'd probably see that being a very common one. And I think it stands to reason just the same. The clinical reasoning behind it's like, why? Well, if I were to put my foot on a brake and have an accident, right, then I'm going to be posteriorly rotated once that impact happens. Or if I fall onto my knee, same thing. You could clinically reason through that why that may be the case. Yeah.
So let's say comparing lumbar, hip, and SI joint, in your experience, in your practice, how, let's say, percentage of each that you see happening, how would you divide that?
As far as what percentages break
that you
down?
See? Yeah. So for example, you see, how often do you see back cases versus hip and SI joint?
Yeah. All right. So you got to put one more thing on that. And that is we're assuming all are derangements, right? So you're saying.
Yeah. So you can compare the same.
Yeah. So we're apples to apples. 80% are lumbar, 15% are, and I'm going to probably get in trouble for this.
This is your practice, not by the books, your practice, your experience. So let's release the pressure.
I would say, and maybe I shouldn't be so precise, 70, 80 probably percent are going to be lumbar. I'd say 10 to 20% are going to be hip, and then the remaining are going to be SI. And again, I think that's a little more fair and conservative, so it doesn't get so many people riled up maybe. But I just don't see a ton of that. And again, it could just be my population. If I saw a ton of motor vehicle stuff, or if I switched out and I did some pre or postpartum stuff, then maybe I would see some different things there too.
Yeah, maybe it's also the population you are seeing, that the specific population that is not MVA, motor vehicle accidents, is not like mostly trauma, not pregnant ladies, and all this population that are more likely to have that kind of problems, right?
Yeah, and they and I think it's important too. And I said this earlier, and I hope people understand this. Our assessment, our NDT assessment, and the person that's using it, hopefully they'll be as unbiased as any person you have ever met when you see that person. So we don't really care what it is, right? We just want to understand it. And so, when I try to be as unbiased as possible. I'm the one that's going to be the most doubtful person in the room. Like, I don't know that changed you. Can you prove me right, or prove that to me that you're different? So, and you'll see that in a lot of us, where it's like, okay, are you better, worse, or same? I'm better. How? So it's not good enough just to tell me that. So how do you feel like you're better? So prove me that that's true, so that we're remaining biased and we're challenging the baselines, because that's the key to this assessment, is that you can't be biased.
The same thing if they say I'm the same, and then you test and they are moving way better, but they are still feeling pain. So in their minds, they are the same. But then you go and test and you see that they're actually better, but they don't realize that.
And but then again, their impression of how they are is the most important impression. So it's like, okay, listen, until your words are different, we got to keep going here and figure this out. So yeah. And so I say that because as a young therapist myself, I'll put the clinical mirror in front of myself I can remember before I got into this that I have an influence towards there being a very, very high prevalence rate of SI joint pain. And I can remember fighting with my internal self about that because I thought, well, this is what I've been taught. This is what I know. And so what I learned there, and just looking back and looking at myself, is I was very biased to that diagnosis. Or that joint. So you just got to remain impartial and use the assessment. The assessment's the true factor in that. So let the assessment take you there.
Yeah. And sometimes it can be difficult just because you know the high prevalence of certain things, and then you want to assume that is there right away, but you gotta be careful.
That's right.
Anything else you want to talk about the hip, SI joint, and back before we move on?
Trying to think here. Anything you can think of that I may have left off? Or I tried to be.
No, because the other questions I had, you already answered. That I was like, before assessing the hip, do you exclude the back as the source first? So you already kind of say the yes, right? You exclude the back first, and then if nothing changed, then you go and assess the hip. Same thing with SI joint, unless you have the patient, as you mentioned, about having the SI joint as the main complaint. So you want to just go straight to the source. But other than that, it looks like the rationale is always exclude the back first and then go to hip and SI joint, right?
Mm-hmm. Yeah, I think that's. And there's a reference in our manual I'm just looking at right now, and it's, this is the Laslett study. It's the McKenzie classification system with a cluster of SI joint provocation tests showed excellent sensitivity and specificity values for the diagnosis of SI joint related pain. That's Laslett 2008. And so that's the reference, and that's in the Journal of Manual Manipulative Therapy. And so that, again, has, I think that's been pretty much the standard of things for a long time, is that, again, inconclusive lumbar exam. And so that's our, that's our strength. So, yeah.
Mm-hmm. Yeah. So if you don't see a lot of SI joint, and when you see probably most are derangement, what would be the odds that have dysfunction or like postural and SI joint?
Yeah, I think it's just like the rest. I mean, it drops off significantly. So if you think about, how often do you see dysfunction in the lumbar spine? How often do you see dysfunction in the hip? How often do you see dysfunction in the SI? Those numbers dramatically drop off as you go along, right? Mm-hmm. And so I wouldn't even, I would be afraid to even put a number on that. It would be rare, I think. And so, again, be careful about, choosing any diagnosis for that matter, because it's something you just can't figure out, right? Oh, well, it must be this because it's not doing what I think it should do, because it's not a derangement. There are other things. I mean, and I probably, if you said, okay, well, and speaking of other, if you said, how many other classifications do you see when we get to the peripheral joint, i.e. hips or shoulders that are structurally compromised? So you do have labral tears, you do have OA, effects, things like that, where the joint is just structurally compromised. And so I probably see a greater diagnosis of other and peripheral joint stuff than I might see as dysfunction versus derangement. Just, so I think there's that to consider. I think the fourth classification we have, which, classically people know it for 3, derangement, dysfunction, posture. I think the other box is probably where our strengths lie, because we're really differentiating against a lot of the other medical diagnoses that come in that box as well.
Yeah, good point. So now let's talk about the McKenzie courses. So I know you've been teaching them virtually. So how has been the experience so far?
I think it's been really good. It's been, I think you hear people talk about assembling a plane while you're in flight. I think Stacy and the folks in Syracuse would agree that seems to be the case. We've been trying to do this along the way as a necessity, as much so as anything. And our faculty, it's been amazing, because I think we've all learned a little bit about each other, and it's all been positive. I mean, we've done it together. So we've had 2 instructors on each course, which I think is, good for the participants, because you're getting two folks at the same time and getting their thoughts and their feedback, and usually someone's available. We got question and answer stuff online. The interactions have been like this, so we've been doing it virtually, and although the boxes are much smaller when you have 25 or 30 people, I think that it allows an interaction that maybe we take for granted, or think that is a better scenario face-to-face, because some people just genuinely just don't like to ask questions. But a lot of it's been the chat box. So there's a chat box feature, and so we encourage people, to ask questions throughout. And so I think we get more interaction that way, because it doesn't seem to be, there's one person really, really comfortable with asking questions and someone in the back that could care less. The person that care less, they may feel like, hey, I got a question. I'm like, okay, this is actually okay. I'll ask that question. And so you get a little bit more broader in participation, I think, somewhat. And I maybe I'm making that up, but I feel like that's the way it works. So the chat, has worked really well. I think the time frame for people to process the courses is a good thing, because the weekends are really fast. This, you go for your 3 or 4 day course, you walk in, it starts, it's a volume of information that you get in that time frame, and you're seeing patients being assessed, and you're trying to put that into your own clinical, experience when you go back, so that you can apply it when you get home. And it's like, wow, that's a lot. And then when you're driving home or flying home, it's like, wow, okay, this, I got it. And then you show up on Monday, it's like, okay, maybe I don't have it. If you're doing the course online, you have a month of time, give or take, to re-listen to podcasts that were recorded by our faculty on different topics. And so they, okay, we're going to talk about SI joint. Well, I want to listen to that again. So I'm going to, listen to that podcast again, listen to the podcast again. Or if it's something about differentiation between maybe it's something about derangements in hips or derangements in knees, and you want to listen to that again. You can take your time, you can, listen through it. And then, so I think the processing of the information, because it is such a volume of things and a different way of learning, teaching, of understanding things, that I think that people have had a chance to do that. Now, lab has been a little difficult, be full disclosure, it's hard, to not be standing over someone going, hey, if you put your hands like this, that'll go better, right? This is the way we want to do it. So that's been a bit of a challenge to get that just right. So there's strengths and shortfalls, I suppose, but overall it's been a really good experience. And I think the participation has been really good. I've had the opportunity to do one exam this year, and there was 3 people that had completed their C and D courses virtually. And everyone on that exam passed, so they passed as well. So it seemed as if, okay, well, you understood what the technique was, and you did well with it. So, and to be honest with you, it's the practice time you put in anyway, right? So we can teach it, but the reality is when you go home, you got to teach it, you got to practice it. So, but it seems like it's going well. Really, I wasn't convinced Gary could do that, to be quite honest with you. So I wasn't sure that I was the material for online things. And so, but it's been really a great learning experience in creating new ways to learn. So it's been fun. I think all of us have gotten better for it.
Yeah, it's just, you have to find a way to adapt. You can't just stop. So everybody's having to try to figure out how to get this done. And then I think it's even us, we get surprised by the results, like doing telehealth or teaching virtually. As you said, I think it's very valuable, the ability that you have to listen again, because it's a lot to process at once. And then you try to write notes and write down everything, but you don't have the time to absorb everything. So I think it's amazing, this ability that you have to listen again. And some people take a little longer to get all the information because it's a lot. And we know every time you take a course, we learn more and more, and something else that you didn't catch it before. And that's how it is. Every time you learn something new, because you can't get it all at once. So I think listening, it helps a lot. You being able to listen to the explanation again, and like I said, the podcast and things. And I would agree with the question, because probably people get intimidated on the room, people that are shy or not, they don't are comfortable speaking up, and they have the questions that they are afraid of asking. So having the chat, that makes a lot easier. So I think it's there for sure are positive sides, and as you said, negative points that will be better in person. But like overall, I think you get the job done, as you said, and people are able to understand and apply, and even having this time frame, I think it helps. Because I remember when I first started, it was so much information, and you go back to your patients and you start doing is like, yeah, that's not working. Like you feel like, okay, I got this. And then you start doing it, as like, so what? And what now? Right. So in the beginning, I think it's very important that you have more time to process everything. Yeah. And I was just going to ask you, the structure, is it still the same? Or did you have to change the structure of the course because it's being virtual?
No, it's pretty well the same setup. I think with the Part D, I know Part D starts out as extremity, but you know, we've talked and discussed that as far as being a potential change on the big picture of things anyway, to incorporate that earlier in the course, and quite honestly, I've taught it that way live as well. And I think it works out really well for the weekend, because then the discussion changes sort of an open forum for, you know, whatever you have questions about from waist down or from neck out, that kind of works for the next 4 days, right? So I think that, you know, that change is not really anything major. I think it's actually a good opportunity to bring that up early. And but as far as structurally goes, you know, the podcasts are sectioned out. You got certain obligations for the first, you know, 2 or 3 weeks, or 1 or 2 weeks, and then you have a live sync session. And then you'll have new assignments. It'll be the next, you know, 3 or 4, and then you'll have another, you know, sync session. And then the last sync session in all the courses is a manual, you know, part of the course where you would, you know, it's kind of hard to obligate someone that's maybe not involved to be available, but we try to encourage people to have a model so they can do the techniques and we can critique them. You'd be surprised how, you know, it's not that hard for us to watch. Yeah. And say, do this, try this, change that, you know, and it still work. And so, yeah, you know, but the hard part there is finding somebody that's really available for, you know, a couple of hours to help you out. Right.
Yeah.
So,
yeah.
But no, the structure's been, you know, good. And I think the biggest thing is like this, is we all sort of hunger for that interaction and feedback and that process to learn and stuff. And so, to continue to be able to do that's been fun, because last year when things shut down, I didn't realize how important it was to do that to me personally. I mean, it was a big deal. It's like, okay, there's a large part of me missing now. I got to do this. So it's been fun.
And is the Institute having presential courses right now, or is all virtual?
Everything
have in person.
There is a live Part A this weekend going on. 𝐏𝐸 is teaching.
Oh yeah, I saw him posting.
Yeah, right. Surprise there, right? And I think it's around New Orleans, and I think there's one in West Virginia. I think 𝐏𝐸 is doing. I was trying to think if there's anything else live. I think those are and then we've got a couple of exams that are full currently. We just had an exam last week. Matter of fact, I think Dave and Scott did that, and then there's another one coming up sometime. But I think there's some, as people are, I think, getting a little more okay with travel and being in a face-to-face environment. I think we're trying to work towards, you know, reinstating some of that stuff, you know, going into the end of the year, first of the year, hopefully. So we'll see. Hopefully it works out that way, and folks will be ready. And the ones that don't really care for the online, you know, part, they'll come be live. Or maybe people like to do a little bit both ways, and they do one course one way and another course another way. So, you know, I think having both, I think we'll always keep that option, because I think it's really been pretty amazing what was put together in a very short period of time. So yeah, that's amazing. Congratulations for all the faculty that are putting the effort and doing that happen. So the show must continue. You got it. Yeah, as long as there's demand, we'll be there, right?
Yeah. So let's transition to our final questions. What is your favorite resource of information? Do you have any paper or anything, books, anything in particular?
I'd like to lean on things that are, you know, I think that are solid research papers, and some of them, you know, ones that have been produced recently have been the Expo study is one of those things that I reference a lot, especially in the environment I'm in now. And I didn't elaborate on that, but I work in Athens, Georgia, So, this time of the year, it's Go Dogs. All right, we play, the Vanderbilt this weekend in your neck of the woods. And so Expos is a big one that I referenced, the 𝐏𝐸𝐴𝐴 study for injections. Again, it's environment that I'm in, trying to help steer people where their next move might be. Those two papers I think, can talk about a lot. And then, of course, 𝐓𝐸𝐴𝐴 study, people would say, well, it's out of date, it's not current. Doesn't matter which exercise, but that study's so well, done so well, and the outcomes of that study is so prevalent even today, or relevant today. It's like, okay, that's a go-to thing. So if someone says, hey, I need to read something, what I'll read, it's like, you got to read 𝐓𝐸𝐴𝐴 study. If you haven't read that study, you need to get it and read it if you're going to do MDT, because it's a great one to have too. So those three studies are some that I talk about a lot, even with patients, because the humility in this is, I don't know what your problem is, but I can give you your best likely chance of how we might proceed. So I'll talk to patients about the studies and the fact that they help steer us in their current. So
yeah, no, that's amazing. Good.
And I'll say this, that my favorite go-to thing in the clinic that I use, and this is, I guess I learned it on my diploma program, is when I talk about, I'm talking to my patients, I'm writing these things down on a dry erase board. That is the number one thing in the clinic that I can't do without, is, using that dry erase board to put information on, because it's just like teaching class. You can hear it, see it, process it. The more times you can see it, or more ways you see it or have that, the better off you are, the better chance you're going to, remember it. So do a lot of that.
It's the teaching inside you that you apply to all your patients or your students. You have to have the board and the old style. That's good. Right. Yeah. And what would be the best advice that you can give to clinicians that are starting their careers?
Oh, wow. I gave this advice to someone a few years back, and I encouraged them, to find a mentor and be an expert. And so that advice to me is, find something that feels right and see it through, right? Find someone to help steer you through those things, because you will have questions and you'll have obstacles and you'll have things that'll try to distract you and steer you away from that course. And to have people that you trust to help you get through that stuff is super, super important. And so I think that would be kind of it, is just, find what feels right to you and be the best at it you can. Yeah.
And what personal qualities and abilities that you think are important to become a successful PT?
Ooh, you gotta love people, right? and variety, I think, because you get a lot of different personalities. And again, with that, I think time and patience and willingness to continue to challenge yourself is important, because, I jokingly say all the time, the first time is always the first time. Well, if you're going about it in the same fashion, then you can go off of that first time, the second time, the third time, the fourth time, the fifth time. So you're drawing off of your experience based on one foundational thing. And so if you have a good, solid assessment and you stay with that assessment, then I think that that you're going to have better success that way. So, I think experience, being patient, challenging yourself, never being satisfied, that kind of stuff, will keep you having fun. Work is work. It always will be. And there's going to be good and bad days, but the vast majority of what you do has to be exciting, I think.
Yeah. Getting the challenge and feeling you're able to help people live better. So I think that's really motivating.
Right.
So Gary, if people want to learn more about you, or if they want to contact you, is there a way that they can reach out?
Sure. The website, I'll steer you towards that. It's the best, it's a great resource for anyone looking for anything as far as MDT stuff goes, but we're on there. My personal email address is there, gwdykes40@yahoo.com. That's probably the best thing. Make sure you put something in the subject box, because I'll trash it if not. And so the email is probably the best thing. And again, from a resource, learn more about me. We have bio things on there. I mean, I jokingly say I'm just an old farm boy from when I grew up. And so I'm not sure there's a lot more to learn from me. I think that's as far as like about me, but but if anybody's got any questions or things like that, I don't do a lot of social media things, and that's all by choice. So you won't find me like Yoav on social media. And so maybe if you send Yoav a message, he can relay that message to me. Maybe that would work, right? So, but yeah, but the email stuff kind of old fashioned that way, and I keep the other stuff to a minimum. Yeah.
Social media is nice, but it's overwhelming. Yeah.
Just can't do it. It's like, okay, do I have that moment in my life today now to do that? No, I do not. So yeah.
It requires a lot of time. So you can get lost very easily there.
And for that reason, I'll thank you for putting your time and effort into that, because we need folks to do that. And so, yeah, I really appreciate your time and effort that you put in as well.
Yeah, thank you. So I appreciate you taking the time to talk to us today and help us with all this very nice information, super helpful. And I just appreciate it. Thank you so much, and hope you have a good weekend.
You too. Thank you much.